Kia ora, everyone. I'm sorry I can't be with you in person, but I'm thankful to John Minto for this opportunity to talk to you about the Canterbury Charity Hospital Trust and about unmet need for secondary, by which we mean hospital level, and elective, by which we mean non-acute healthcare services. Healthcare rationing in New Zealand really started with the New Zealand health reforms in the 1990s. These were mainly introduced with what was called the National Waiting Time Project in 1998. Since then, many people have been refused a first specialist assessment, and thousands of people have been dropped off waiting lists. These numbers represent those that happened in just the Canterbury region up to 2006. In response to these health reforms, we got together with the community in Canterbury, and with their donations of money, and that is the only source of funding we have, we built this state-of-the-art day hospital in Bishopdale, Christchurch. It has operating theatres, an endoscopy suite, a dental unit, a counselling centre, a teaching unit, and a number of other facilities. And basically a skeleton staff, and 290 volunteers provide a free service to those people who have been turned down for treatment by the Canterbury District Health Board and who can't afford to pay for private care. This table summarises the activities up to the end of 2019. Here on the left, you see the sorts of services we provide. These include gynecology, general surgery, orthopedics, eye surgery, etc. And since 2007, we have done over 14,000 procedures on people and seen over 20,000 people. How big is the unmet need for secondary or hospital level care? Well, it's very interesting. The primary need, the need for primary care or general practice, is measured annually by the New Zealand Health Survey. But the secondary unmet need, the need for level care, has never been, and there is no intention really of measuring it in this country. Because of this hole in the knowledge gap, we put together an expert panel, and we did a small pilot study in Auckland and Christchurch in 2016. Here is the results of our study on the right. This suggested that 9% of the adult population needed hospital-level care and could not access it. We've been trying to get government since 2014 to do this study regularly. In a survey of this kind, you would need to ask at least 6 questions, and preferably 12, in order to get a good sample. Under pressure, the Ministry of Health has now agreed to ask part of 1 question in next year's national survey. So, I'm afraid this talk is really based upon a list of proposals, and our first and probably our most important proposal is that the Ministry of Health should undertake a comprehensive national population survey to assess the quantity and the nature of unmet secondary elective health care every 3 years. We believe that this should be incorporated in the New Zealand Health Survey, and that really rationing and a logical use of secondary services can never be done until this sort of survey is undertaken. Why is the unmet need so big? Well, the health reforms changed the culture of our healthcare system from a service to a business model. As described in our article here, neoliberal policies and the business model really failed us in New Zealand. But the managerialism and the underfunding of health that it created has persisted ever since. And this has left a big funding shortfall. So our second proposal is that we need a new model of healthcare as a service, not as a business. And this needs to be created to encompass all aspects, including personal health, racism, cultural, and socio-economic determinants of health. How big is the funding shortfall? Well, under the business model, health funding never kept up with need. As our 2016 article shows, between 2010 and 2015 alone, vote health as a percentage of GDP fell from the very low level of 6.3% down to an even lower level of 5.9%. Now, massive data from the European Union has shown that investment in health actually saves money, especially during periods of austerity like the one we are currently about to face. So our third proposal is that a new investment model is required for secondary elective healthcare that takes into account, firstly, the backfall of funding which we have now created. Secondly, the current unmet need, including all the socio-economic factors that we've been talking about, and the changing in population demographics. Furthermore, we have to take into account the future service developments that will occur. Indeed, we need an investment policy for the whole of health funding. We recommend proportionate universalism is the model as described in this 2015 paper for dealing with the socio-economic deprivation factor. Unfortunately, time is short, and I haven't sufficient time to go through all the proposals that we would make for the improvement of secondary health care. However, they are listed in much more detail in this article that we published this year in the International Medical Journal. And in fact, for those who are interested, I list here all the articles on which this talk is based. Thank you everyone for your attention. Kia ora.
Kia ora. Tēnā koe mātua mō tō kōrero I tēnei wā. I think there's something fundamentally munted about a health system that prioritises the dollar bill over the whole order of people and their whānau. So kia ora, and you can all see that there's more detail, more proposals to come. So ngā mihi nui ki a koe mātua. Kia ora, ho mai te paki anō.